we unite, oh, do the right thing. Do the right thing. Situation don't they get a CB. My brother, sister, get your BBC. Make we unite, make we vote UB. Now my president, me, I want better tomorrow. Me no want to load, no, no. Not the person will be. Want better tomorrow. No go for to load, no, no. If you don't want to be, it means say you don't want to be.
Me I go for T.O.B. Peter Obi. Say now you we want to.
You we want to.
Now you we want to.
What I want to do is to take Nigeria from consumption to production.
Ana son ci gaban Najeriya a zaba Peter Obi.
fún ìlọsíwájú orílẹ̀-èdè nàìjíríà dìbò fún pétérù òbí.
maka ọdịmma Naịjirịa ka anyị tụnyere na Peter Obi.
Vote Peter Obi.
Vote Peter Obi.
Vote Peter Obi. Vote Peter Obi.
Record. Are you obedient? Are you obedient? Now my president you be. Me I want better tomorrow. Me no want to load, no, no. Not the person will be me. If you want better tomorrow, no go vote to load, no, no. I am a class go as you see me so at the front line, no. At the front line, no. But you want mine, no, make we unite, oh, do the right thing. Do the right thing. Situation don't they get a CB. My brother, sister, get your BBC. Make we unite, make we vote UB. Now my president, me, I want better tomorrow. Me no want to load, no, no. Not the person will be. Want better tomorrow. No go for to load, no, no. If you don't want to be, it means say you don't want to be.
Me I go for T.O.B. Peter Obi. Say now you we want to.
You we want to.
Now you we want to.
What I want to do is to take Nigeria from consumption to production.
Ana son ci gaban Najeriya a zaba
Peter Obi.
Vote Peter Obi.
Record. Are you obedient? Are you obedient? Now my president you be. Me I want better tomorrow. Me no want to load, no, no. Not the person will be me. If you want better tomorrow, no go vote to load, no, no. I am a class go as you see me so at the front line, no. At the front line, no. But you want mine, no, make we unite, oh, do the right thing. Do the right thing. Situation don't they get a CB. My brother, sister, get your BBC. Make we unite, make we vote UB. Now my president, me, I want better tomorrow. Me no want to load, no, no. Not the person will be. Want better tomorrow. No go for to load, no, no. If you don't want to be, it means say you don't want to be.
Me I go for T.O.B. Peter Obi. Say now you we want to.
You we want to.
Now you we want to.
What I want to do is to take Nigeria from consumption to production.
Ana son ci gaban Najeriya a zaba Peter Obi.
fún ìlọsíwájú orílẹ̀-èdè nàìjíríà dìbò fún pétérù òbí.
maka ọdịmma Naijiria ka anyị tụnyere nụ Peter Obi.
Vote Peter Obi.
Peter Obi.
Vote Peter Obi.
Vote Peter Obi.
Record. Are you obedient? Are you obedient?
Now my president you be. Me I want better tomorrow. Me no want to load, no. Now the person will be me. If you want better tomorrow, no go vote to load, no.
I am a class go as you see me so at the front line no.
At the front line,
But you want mind no make we unite oh, do the right thing.
do the right thing.
Situation don't they get a CB? My brother, sister, get your BBC. Make we unite, make we vote you be.
Now my president you be. Me I want better tomorrow. Me no want to load, no. Now the person will be me. If you want better tomorrow, no go vote to load, no.
If you don't want to be, it means say you don't want to be.
Me I go vote Obi. Peter Obi. Say now you we want to.
You we want to.
Now you we want to.
What I want to do is to take Nigeria from consumption to production.
In ana son ci gaban Najeriya a zaba Peter Obi.
fún ìlọsíwájú orílẹ̀-èdè nàìjíríà dìbò fún pétérù òbí.
maka ọdịmma Naijiria ka anyị tụnyere nụ Peter Obi.
Vote Peter Obi.
Vote Peter Obi.
Vote Peter Obi.
Vote Peter Obi.
Record. Are you obedient? Are you obedient?
Now my president you be. Me I want better tomorrow. Me no want to load, no. Now the person will be me. If you want better tomorrow, no go vote to load, no.
I am a class go as you see me so at the front line no.
At the front line,
But you want mind no make we unite oh, do the right
Hello, can you hear me now?
Yes, we can.
All right. Okay, sorry
Can
for
hear you
that.
now.
Okay, thank you very much for coming on 7. We already have viewers online. Dr. Shegu, okay, thank you very much for coming on. We already have okay, thank you very much for coming on. Okay, so we are going to take and the first and the second stanza of the national anthem, after which Dr. Shegu will make some of Daughters of P2B and read the citation of our speaker and invite our speaker to. So I'm going to share the anthem so we can sing along wherever.
I think you should just that the last time that sing along didn't go well. So
do not worry. Let's see. Okay. Sorry for that. That's the intro. Just a minute. Let me share the correct anthem. All right. All right. And by Experience Lagos 2020. Dr. Shegu, please, brief opening remarks and the citation of the speaker. Thank you.
Chima, while I'm doing that, I think you should restart your device. The network was going on and off and on and off. Okay? So you can make me host while I'm making my remarks, and you can just restart your device.
Okay.
Good evening, ladies and gentlemen. It gives me another singular honor to welcome you to this episode of Health for a New Nigeria. Events in the last weeks are pointing direction that this change you are looking for will happen. Just this afternoon, I hosted for the Afenifero Youth League, and the whole of the Southwest is firmly behind us. The idea of the Health for a New Nigeria is that our mission is not just to get Mr. Peter Obi, the president of Nigeria. It's also to get him to revitalize the health industry. So this series, this 13-topic series, is to provide depth of the key issues and at the end of the day, there will be a compendium of position papers that Mr. President can start working on from day one. So we are all here gathered to do this all-important task. Industry. And I'm proud of everything we have done so far. Dr. Ngozi Onyeka, I have known for over 20 years. Maybe she doesn't remember. The very first time I met her was in the Society for Quality in Healthcare meeting in sometimes 2004, 2005, thereabouts. So almost 18 years. And I've admired her zeal, her determination, her doggedness. I remember in the heat of COVID, when I called her for a partnership, she said she's fired, she wants to give everything. But thankfully, she didn't. So it gives me singular honor to read this citation of one of the true patriots of Nigeria. Dr. Ngozi Onyeka, if I pronounce that well, is a 1982 graduate of the College of Medicine, University of Ibadan. Still ranked the best university in Nigeria. Her additional qualifications in medicine are fellow of the West African College of Physicians and Pediatrics and a certificate in travel health. She holds an executive MBA from the Lagos Business School. She has a diverse career over the past 40 years in both the public and the private role. She's the founder and managing director of Paylon Memorial Hospital. Note, not medical director, managing director. Paylon Multi-Specialist Hospital is a boutique practice. I wonder what that means. The first hospital in Africa to attain level 5 in self-care. First in Africa. Self-care is a quality improvement methodology for private hospitals. I make bold to say it was actually a joint venture between the Joint Commission International and the Kusasa of South Africa. So self-care attained that level 5 in 2016 and maintained it till 2020. It's a 2-time winner of the Nigerian Healthcare Excellence Award for Self-Care Facility of the Year in 2018 and 2020. And most recently, awarded the most compliant hospital in Lagos by the Health Facilities Monitoring and Accreditation Agency. She was the company medical advisor of Nigerian breweries from 2000 to 2010 and had the distinction of becoming the first female manager in the then 64-year-old company. Another first. Ngozi sits on the board of several organizations, including the Leadway Health Insurance and Farm Access Nigeria, Society of Quality in Healthcare. She chairs the Audit Committee of the Pediatric Association of Nigeria. She is also the head, it's not written here, of the Medical Committee of the Queen's College Road Girls Association. Isn't it? Because I remember they hosted Peter Obi recently. I saw the pictures and I was jealous, but I can't just go to Queen's College Road Girls now. I'll be really out of place. She's a mother of 2 children and a proud grandma. Really? Oh, wow. Some people shall. She's a melophile, worker, and podophile. So I think that's where you start. Tell us what melophile and podophile means before you start talking about primary care. So, ladies and gentlemen, Dr. Ngozi Onye.
Good evening, everybody. So I put those in there to make myself feel very good. So a melophile is, sorry about that. A melophile is someone who loves music. I love music. And then a podophile is someone who loves to travel. I love to travel. So thank you. So thank you for inviting me to give this talk. I'm going to share my screen now because I like to be guided in what I say. And also to say that, so just a minute as I share my screen. Just to say, well, as a background, my first contact with Peter Obi was when he was the governor, and I was traveling. Sorry, I can't seem to find what I want to share. Just a minute. Gosh, I think I better use my iPad. I'm much happier on my iPad than on this, but I was traveling and I was at the airport queuing up to get on the flight. And I looked and I thought I saw somebody like Peter Obi, but I thought he couldn't be queuing up. In fact, sitting on his luggage. So he had his travel bag and he was like holding onto his travel bag and basically sitting on it. And I thought it can't be. So I walked up to him. I said, "Sorry, are you Peter Obi?" And he says, "Yes." I said, "But you're at the airport." He said, "Yeah, I'm traveling," And that amazed me, And since then, I kept an eye on him because I won't strictly define myself as a politician. I'm very politically aware because I like to define myself more as a citizen than anything else because I recognize that whatever happens to Nigeria will concern me. And so I prefer to call myself a citizen than to call myself a politician. And so, like I said, I kept a close eye on him and followed his progress. Not too long ago, I traveled with him again at the beginning of this year. And I walked up to him and I said to him, "Sir, have you decided up your mind if you want to contest for president?" Because the idea had been floated. And he said, "I haven't made up my mind. I'm still consulting, the things politicians will usually say." And so I gave him my card. And I said, "Sir, if you do decide you want to run, please let me know. I will do anything I can to support you." He never got back to me, by the way. But we have a mutual friend, and that mutual friend is Johnson Chukwu, who was my classmate in MBA and sort of knows I have a lot of admiration for His Excellency. And so he let me know. And like they say, the rest is history. I'm giving all this background so that to give myself time to log on with my with my iPad, which I've just done now. And then now I've logged on with my iPad. I'm sorry, I'm going to log out from the other device. Okay. Okay. So I hope it's not echoing now. Am I echoing?
Now recording in progress.
Okay. Okay, good. So it's fine now. No, it's not. Just need to. Sorry, I'm trying to get off this. I don't know what I've done. That's what happens when you get a 62-year-old man trying to technology.
Dr. Shego, I'm thinking that a few minutes to them while we go ahead and reintroduce the structure of Daughters of P2P while we are giving in terms of collaborations with support groups, so that in the next 2 minutes, Dr. Ngozi can actually come back and join us.
Okay.
I'm on again, but Shagun, you need to give me rights now, sharing rights.
Okay.
It's Chima.
Okay, Chima, can you please give me sharing rights? Sorry about it.
Okay. Okay. You are now a co-host, man.
Yes, I know. I'm trying to share my screen. I had downloaded it on my computer, but I think what happened was that a phone call came to try to come through, and it threw me off, and I pressed something in error. So I'm supposed to be talking about primary health care in the new Nigeria. Okay. And I suspect that the reason...
please, okay.
And I suspect the reason why I was asked to talk on this topic is because Shegu and I, we both participate in the same scheme with Delta State Contributory Health Scheme. So here is the outline of my presentation. I'm sorry about the blip. And here's a picture that's making Shagun jealous. So this was last Sunday when we celebrated Queen's College at 95. And I will say that we're all sitting quietly in the hall, and there were other representatives of other political parties. I didn't know because I wasn't a part of the planning committee. So Mr. Femi Pedro was there to speak on behalf of APC. And Mr. Funsho Doherty on behalf of ADC. He's the gubernatorial candidate for ADC. Both of them have wives that are old girls of Queen's College. And we had seen them and we had recognized them and they had spoken in the forum. And then suddenly I heard a noise coming from somewhere. And I panicked a bit. I wondered what it was. And then we looked and Mr. Peter Obi was walking in and all the old girls. And when I say old girls, I mean some of us as old as having left Queen's College in 1953. I left in 75. We all went wild and everybody was clapping and shouting. I saw that look on his face, a bemused look that he often will have when he sees the kind of reception, he's receiving. And it was after he had spoken to us that I grabbed him and took this picture. You would think I knew him from before. But anyway, so primary health care, talking about primary health care. So talking about this, I should introduce myself a bit. I think I did most of that already. Shagun already gave a bit of my biodata. I want to talk more about the fact that I'm not a politician and I must put that out there. But like I said, I am a citizen. I have the larger interest of Nigeria at heart. I've practiced here for 40 years as a doctor. I've never practiced outside Nigeria. I took a decision to stay, a decision that sometimes I have regretted in the past, but I've cast my lot with this nation, and I will do everything in my power. I have children, I have grandchildren in this country. I'll do everything in my power to ensure that I contribute my own bit to nation building. And I think this is my own part of my own contribution to nation building. So primary healthcare, I tried to get a definition for primary healthcare. Primary healthcare has an overarching goal of creating better health for all. And what is it? It is essential healthcare based on scientifically sound and socially acceptable methods and technology. Because healthcare should not be a short-lived intervention, so one time equipping one big hospital and making it a center of excellence, or a one-time medical outreach to cure cataracts from for everybody that attends the outreach. But it should be an ongoing process of constantly improving the lives of people and alleviating the underlying socioeconomic determinants of health. And I'm happy that's becoming very, very important now, those socioeconomic determinants of health. Health is not all about coming to hospital, seeing a doctor, and getting lab tests and getting medication. But health has all kinds of determinants that are just as important. And I'm going to use my experience in Delta State as a case study for this presentation, and then we'll see how many things intertwine into health. So there are principles that will link health, development, and that will also advocate political intervention. So the principles will link health with development and political intervention. There are 5 elements of primary health care. Sorry, this is kind of like small. The first will be reducing exclusion and disparities in healthcare. So just getting rid of health inequities. We're not trying to make health equal. It can never be equal anywhere, not even in the best societies in the world. Even the UK that has the NHS, we cannot consider health equal. The healthcare that the Queen receives is not the same healthcare that the common man on the street receives. But the common man on the street receives good enough healthcare. In fact, probably better than good enough healthcare. And so when you want to reduce exclusion and disparities, we will have universal coverage reforms. So they identified some elements and introduced some reforms to, this was in Alma Ata, of course, in 1978, when people gathered to discuss healthcare. And then there was the Alma Ata Declaration that led to primary healthcare. And they said the first thing is to reduce exclusion and disparity. So they had universal coverage reforms. They talked about meeting needs and expectations. So they talked about service delivery reforms. So meeting needs. So it's not one size fits all. They must find out what the needs of the local community is, and then those needs must be met. And that will lead to service delivery reforms. Then there will be integrating health into all sectors. And that will lead to public policy reforms. And that's probably, in my opinion, the most important part, that public policy reforms, because the 2 legs of health will be public health and primary health care. They're the 2 legs of health, the 2 most important elements of health. Okay. And then there's, of course, collaborative models of policy dialogue. So that's leadership reforms. I think we will assume that if and when His Excellency Peter Obi becomes the president of Nigeria, that the leadership reforms will already have started just by getting the right leader in place. And he will surround himself with other leaders who will be the right type. And then, of course, increasing stakeholder participation. This was 1978, long before we started talking about things like patient-centered care. But patient-centered care is all about increasing stakeholder participation. So now health will be managed jointly by the patients and the healthcare providers. So these Okay, so I will talk now about primary healthcare in the AMI healthcare facility, and I'm going to use this as a case study to discuss primary healthcare. So first of all, reducing exclusion and disparities. The first thing was universal coverage reforms. Let me start by saying that the model that's being used in Delta State was first developed and canvassed in Lagos State, and I participated in trying to provide that kind of healthcare in Lagos State. For some reason or the other, it didn't take off. But because I had participated in trying to provide primary healthcare in Lagos State, when Delta State set up a contributory health, it's a mandatory contributory health insurance scheme. And when they sent out a request for proposals, I put in my proposal, and so did Shegun's organization, to provide healthcare. And so it was the learning curve was not so steep for them because we had already done most of the learning in Lagos. And it was very easy to take off. So what it is that there's a contributory health scheme that was established by the government of Dr. Ifeanyi Okowa, the current president and governor, set up this commission and a mandatory health insurance scheme. Something as small as 7,000 naira a year for anybody who wants to participate, and that should cover for primary health care. They identified some people who they felt were unable to pay for themselves, the really impoverished. They also identified what they call the legacy group. Those are the children under the age of 5 and pregnant women who the state will cover for. Every other person should be insured. They've already gained quite a bit of traction. I think something like maybe 25% to 30% of Deltans are already covered by the scheme. So everybody in the formal sector have been covered, but quite a few in the informal sector, including retirees, have also been involved. So the first thing was we tried to develop human resource, because the biggest challenge in Delta will have been human resource. AMI is a very, I don't know if there's anybody from AMI on this group, but AMI is not the most developed of Delta, of Nigeria for that matter. There had been no power for about 8 years prior to when we went to AMI. But I'll say something that struck. So the process of deciding who will provide healthcare in AMI was a very simple and straightforward one. And we're very transparent. We went and we cast ballots and we picked. And I picked two healthcare centers. I visited AMI, and what struck me about AMI was that all the equipment, so the health center was one of the 30,000 health centers that have been developed in Nigeria, of which only 20% are functional. So 30,000 primary healthcare centers in Nigeria, but only 20%. 20% of 30,000 will be something like 60. No, 600. So only about 600. No, that's wrong. My bad. Should that be 6,000? Only 6,000 are functional in Nigeria today of 30,000. But this one had been built, quite nicely built, commissioned, I hear, by President Jonathan himself, well equipped. And after that day of the commissioning, the doors were locked and nothing. I went to it for the first time in 2019, February of 2019, to see the place. Think of when President Jonathan stopped being the president of Nigeria. But 2019, all the equipment had been built 8 years before, and all the equipment, everything, including fridges, which can be useful in homes, were locked up in a store, just in their cartons, just the way they had been given to the healthcare center. So what struck me was that these are honest people, and I felt I would want to cast my lot with them. And so this was AMI. The first day I went there to look at the place, and they already had a signpost on because Delta State government was going to was one of the centers they were going to use. So the first thing was we didn't have people there to start the work. So these are people who came from Lagos. Since I already run an organization in Lagos, I took some of my staff from Lagos. Doctor, nurse, lab scientist, pharmacist, and a radiographer, because we had an ultrasound scan. So the plan was we will get to Amai, we will employ locals in Amai. We already did that. We had already employed them. So this pioneering team went there and spent 1 month there, just trying to imbue the culture of the organization that they worked for in Lagos, in the locals there, trying to introduce them to technology, trying to just transfer skills to them. And they stayed happily for 1 month and they succeeded. And this was the first day of when we arrived. And the first day when we opened our doors, which I think was the 3rd of September. So we tried to meet the needs and expectations of the people. As you can see, quite a few children and pregnant women. That's the major thing we saw. For the first time in my life, I saw Kwashoko again. I hadn't seen Kwashoko in a long time. I saw a bit of some Erasmus as a resident in Luth, but I didn't see Kwashoko. But for the first time, I saw children with Kwashoko again. Quite a few. Many of the children who came there were malnourished, different degrees of malnutrition. And what is interesting to me, that it's an agrarian society where they plant things, a lot of food. It's also a society that has water. It's riverine. So it's almost one of the oil-producing communities, really. And very riverine, so a lot of fish. But when you asked the mothers, Madam, why your picking be like this? The simple answer was, what does the child eat in the morning? It was always rice or eba for breakfast. So it was purely ignorance. So the first thing to address was to educate them about what a good diet constitutes. Most of the people you see here, apart from myself on this screen, are indigenes of my. So we employed a manager with an engineer who was not doing much in a very brilliant man, by the way. Ended up being a drunkard, but very brilliant man. Then we employed nurses, as you can see on the screen. And of course, we started, and it was well received. Before we started, so what I've done is I've identified the different elements and I've addressed the different elements. So the first was meeting expectations and needs. So what was the commonest problem? Malaria. A lot of children had malaria. So I know we overdiagnosed malaria in Lagos. When I say we, I mean people. But in my own hospital in highbrow VI, sometimes in a whole year, we may see only 3 cases of malaria, proven malaria. And because we are evidence-based and guideline-driven, we do not treat malaria presumptively. We must do a malaria test and we must get a result before we treat malaria. So sometimes in a whole year, we may see 3. Between the maximum we'll see of cases of malaria in Lagos will be 20. So it was unbelievable to get to Amma, and virtually everybody who came to the clinic tested positive for malaria. They had huge spleens, they had huge livers, and the children were anemic. I remember the first day, the pharmacist had to donate her own blood. We cross-matched it quickly because she was O positive and transfused the child like that to save a life. I think the child came with the PCV of 6 or 7, something really low, But I'm glad to say we're able to save that child's life because the lab tech was also quite good. He was able to get us a blood bag and able to bleed the pharmacist and so the pharmacist from Lagos. It's also important to say that there are other cadre of healthcare workers beyond the traditional nurses, registered nurses, and midwives. They are the community health extension workers, and they are very important in providing healthcare. They come from the community. They're not that educated, but they're able to take on some of the tasks of nurses. So they're able to share tasks or even totally assume some of the tasks. So the vital signs. So the sometimes the setting of lines, and those kind of tasks. They are trained and they're able to take them. They are used to following standing orders, so they're not giving too much discretion in taking decisions in health, in the treatment, but they're able to follow standing orders. So of course, they have to be well-written, simple guidelines for them to follow, very clear guidelines and algorithms for them to follow. Then, before we started, so one of the reasons why it failed in Lagos, so let me start by saying that there has to be a policy reform. Like, I must give it to Dr. Okowa. He had done a reasonably decent job in Delta State in terms of healthcare. So the first thing was establishing the commission and putting the quite energetic and quite proactive Dr. Ben as the Director General of the commission. And then they went and decided to partner with private hospitals, people who are already running the private hospitals, wherever. So the people from Warri and the people from Onitsha and the people from Lagos and wherever you, if you indicated interest and you met the criteria, because there were the criteria that you had to meet for them to select to be able to go into this partnership. So there was a reform in the policy. So they left the functional health, primary healthcare centers. They left them to continue to run, the one that employed staff directly and some government workers. But then they gave us buildings. But in addition to the buildings, they also gave us access to what is considered cheap finance. At least it was supposed to be single digits compared to the double digits we have in Nigeria through the Bank of Industry. The next thing is, one of the reasons why the attempt in Lagos failed was that there was resistance from the community. So we had done very fine in Lagos and they had allocated hospitals to us. But when people went there to try and claim the hospitals that had been allocated to them, what they met was that they met stiff resistance from the community, starting with the politicians. So the politicians felt the government is giving our hospitals, our clinics to private doctors, and they just totally refused. So the first thing we did before we started, so the pictures are not in order. I'm just following the order of the elements of primary healthcare. So the first thing we did after they engaged us was we went to the community. In the middle picture, I was talking with the king of my kingdom. So they have a king there, a young man relatively young man, who's actually a healthcare worker in the UK, but he's the king of the kingdom. I had to talk with him and explain what we're coming to do. We met the various chiefs. We had a town hall meeting in the town hall. They do have a town hall. And we explained to them what we're there to do. And there was 100% buy-in. In these days of insecurity, the only way I was going to do this is if I felt safe in that community. I have never once gone there with policemen or anything. I need to feel safe in the community because I feel if the security doesn't come from the people there, even unless I have heavily armed policemen like 10 or 20 surrounding me, one cannot be safe. So when I was sure that we were welcome there, that's when we moved. Then we went trying to increase stakeholder participation. I talked with the women. I appealed to the feminine sentiment. I'm a woman, please support me. So here I am with the women. I went to the local government councillor. He's in this picture, the man in the green shirt and 3/4 or knee-length jeans was an honorable. So we went to meet with him and he gave us food and all that with the team. So we met with them and we started. This is the building that was given to us. This was it when we started. So the one on the left, on my left, was the building when it was handed over to us. And it was handed over to us, I think, in April. And we started in September. This was the building where we started in September. We bought an ambulance. I thought it was important to buy an ambulance because I realized that it was going to be a comprehensive health center there, the theater there, but I realized that there will sometimes be cases that will be beyond what we could handle. And I wanted there to be a safe way of transferring the patients to another facility where they could be handled. So that's the ambulance. which was a Tokumbo, very old, but it works. It still works now. Ambulance it can move patients, and it moves patients safely. We got a donation of a generator because there was no power. There had been no power for 8 years. So we got a donation of a generator from IHS Towers. IHS Towers, they refurbish the old generators that they used to power their masts. And then they give them out, they donate them. If they meet certain criteria, they will donate. So that's the generator, the 40 kVA, or it is the 40 kVA mechanical generator. This is pharmacy in Amai, and that's the pharmacy technician. This is our pharmacy in Amai. Nothing fancy. I will tell you that renovating and everything cost us a maximum of 25 million. Everything, including equipping and the initial working capital, 25 million. And Delta State gave us access to between 20 and I think 40 million through the Bank of Industry at 9% interest. I took 20 million because I hate debt. Most women are not comfortable with loans and things. Okay. So this is the lab. We had the basic lab equipment that we required. We had an auto analyzer for full blood count. We did rapid tests for malaria. We could do electrolytes and so on. So that's the lab that we can do. This is the doctor's in his consulting room, the first doctor we had. There's also an ECG machine and an ultrasound scan, black and white ultrasound scan, but it's functional. The man in the red scrubs, it's a community health extension worker, taking vital signs of registering a child. And the lady on top is a nurse doing vital signs for a patient. This is what our waiting room looks like. Now it's a lot fuller than this. This was the very beginning. And there's a mother and a child. Very typical. Those are the people we see the most in our mind. Pregnant women, the fertility rate is extremely high there. And I'm happy, well, okay, we'll go on to that. So this is the patient on admission in the ward. This is what the wards look like. Nothing fancy, but clean, functional, meeting the needs of the people. This is the operating theater with an operating light and a bed, a table that moves. There's a monitor there. So the suction machine is not very obvious, but there's a suction machine there. Of course, there's oxygen somewhere in there. This is the labor ward with a delivery bed and a resuscitator for the baby, suction machine, steps for the. So just meeting the needs of the people. So we've been in operation now for 3 years. Recently, I had a challenge, that's a separate matter, and I was thinking of closing the place down because, yeah, that will also come later in the presentation. And when I spoke to the chairman of our advisory board, by the way, I set up one of the first things I did was set up an advisory board, and I used the local. So the chairman of our advisory board is this gentleman here, who is the man with the coral beads on his neck in this picture. He's designated as the prime minister of the Amai Kingdom. And because the king of the Amai Kingdom is a young man who's still in employment, he often is the one deputizing for him. So I made him the chairman of the advisory committee. So when I had discussed with him and I said, I'm tired, and I'll explain why I was tired, that I will close the place down. He begged me, he said, don't. He said, the Amai Center has become a referral center for that community. Somebody I know, a friend of mine, donated a $10 million hospital to a church diocese around Amai, $10 million, very wealthy. That center uses Amai as a referral center because unfortunately, he donated it to the diocese. He didn't donate it to an order that is already involved in healthcare. So it's very well equipped, but poorly run. So the prime minister said to me, please don't even think about it. He said the community has come to depend upon it, And then he says, they are very lucky. Everything they do there goes well. I don't know if it is luck. I believe in the grace of God, but I also believe in the fact that processes were put in place to ensure that things go well. So what has gone well for us so far? First, that there's wide acceptance. We're now a referral center from neighboring cities. I mean, not cities, communities. So that should have been communities, please. There's no city. It has a very good reputation. They think, oh, if you go to Amai, they will solve your problem. By the way, I've only ever employed medical officers there. It has now become the standard to beat in that neighborhood. We employ locals, and I hear we pay the best wages. The Prime Minister was in Lagos at the time when I called him. I was calling to say I'm coming to Amai, and he said, oh, but I'm in Lagos. So he came to visit me in the hospital in Victoria Island, and he came in the company of his son who lives in Lagos. And he kept saying to his son at least 4 times, they pay very well. They pay better than the university, because there's a university close to the community, Novena University. They pay better than the university. They pay very well. Because I realized that I couldn't pay them less. The doctor belongs to the doctor's group of people. I wasn't going to pay him less than I pay the doctors in Lagos, considering in the first place he's the only one there. And then he will know what his colleagues, because we're very transparent about the way we run the organization. So he will know what his colleagues. So the pharmatech, because we don't have a pharmacist, is paid what we pay the pharmatech in Lagos. The lab tech is paid what we pay lab techs in Lagos. So they are relatively well paid, and they were very happy. Then we tried to develop human resource for health. Like I said, we took the group to Amai. They stayed for 1 month. But the biggest strength I think we have as an organization is that we have WhatsApp chat groups. Thank God for technology, for all cadre of healthcare workers. So we have Pelon doctors and Pelon nurses and Pelon lab scientists and Pelon pharmacists and so on, and even Pelon admin. And everybody in Amai also belongs to their own professional group, apart from the Amai group. They all belong to the same group. Sorry, I should adjust my camera. Sorry, what's the problem with my camera? I'm not quite sure I know what the problem is.
So your face is not fully captured.
Not seeing, I'm sorry, I apologize. Okay. So I hope it's better now. So I said, so we have we have clinical meetings every Thursday. They attend the clinical meetings every Thursday. We have heads of department meetings, so the admin people also will join in the heads of department meetings. We have the doctor in Amai makes presentations to when we have clinical meetings. Sometimes he's made presentations as well. I mean, he made one of the most brilliant presentations I've seen a medical officer make. So they are also a notch higher than they were before they joined us. We rented accommodation for the doctor near the hospital, because the first doctor, who has left, by the way, did not come from that neighborhood. So we rented accommodation and tried to make it decent and put power and so on. So people come there to charge phones. So the clinic is now almost like a community center of sorts. Okay. Since we started, we haven't lost one pregnant woman. And I'm sure the largest number of things we've had there are deliveries. I can check my phone. I didn't think it was very relevant, but to the number of deliveries we've had in 3 years, twins, singletons, so maternal mortality is 0. We have had about 5 IUDs, so the babies were dead, fetal death before the patients came in, but no baby born there, died after they were born. But about 5 were already dead in utero before the mothers presented. I don't think we've recorded any this year, but in the first 2 years we did. We lost 1 child to severe anemia and malaria. So the child was about 3 that died of severe anemia and malaria. Otherwise, mortality, Then initially, I know the road between the Novena University and the health center. A short road, maybe maximum 2 kilometers, maybe maximum, probably less. But it's very bad and it's not motorable. And often when I will complain that we're not getting enough patients coming to the hospital, I will be told that because of the roads. I sent a message to the governor. I told Dr. Ben, and at the meeting in Abuja recently, commitment was made that this government will make sure that they tar that road. So these are the social determinants of health beyond the clinic. When I noticed that the children were malnourished, at the time, Mrs. Mariam Owais, another OGQC, was in charge of the school feeding program. I reached her to say that the school in Amai, why are the children not being fed? And she said that the lady in charge of school feeding, she gave me the lady's number and I sent the lady a number and I told her that these children are not being fed. She intervened. School enrollment increased, if only because they knew they were going to get food. And of course, the lady started feeding the children. Social determinants of health. Family planning, we've introduced it because they have very high fertility rates, simply because they don't know about family planning. So we've introduced family planning and it's well received. We have the advisory committee that we engage and carry along, and we need them to support us because without their commitment, we're not able to continue. I established very strong referral channels with Obiariko General Hospital. So I went there to meet people and establish relationships with them. And when people become very ill, we put them in the ambulance, and barring that difficult 1 or 2 kilometers of road, the rest of the road is very good, and we take the patients there. We did not need to build any new infrastructure, and that's so important to me. We did not build anything. We renovated an existing building. And indeed, there are 2 more hospital clinics that have been assigned to me, but I've refused to take them on yet. They're already well built too. So all I will need to do is renovate if I decide to take them on. We provided water. So even other people in the community come to fetch water there because we dug a borehole. There's a generator. Like I said, people come there to charge their phones because there's power there. We must have power there. We need to go into solar now because with the cost of diesel now, running the generator isn't so good. But what has not gone so well for us? Sorry, it's not showing here, but 3 things I will talk about that have not gone so well for us. The first is the security issue. So this week, the hospital has been, the clinic center, that's what it's called, the center. The center was closed for about 3 days toward the end of last week because there was sporadic shooting and fighting. Like I said, it's an oil, one of the fringe oil producing communities. So there was fighting between 2 communities, gunshots, everything. So we had to close down for a while. Also, I must say that I don't go there very often. And the reason why I don't go there very often is because I don't feel safe anymore. And the reason why I don't feel safe anymore is because I started, there were lots of leakages, It was obvious that pilfering and all kinds of things were going on. And therefore, I didn't feel safe to visit there as often as I would have wanted to, as often as I planned to when I took on this assignment. And nobody from Lagos too is visiting as often. So if things had gone the way we had hoped, then at least once a month, the first 6 months before the pandemic, because we started September of 2019 and then the pandemic was in February. But in that period, between September and the pandemic, one person from the hospital was going there every month, go and spend 2 or 3 days with them just to see what's going on. I went, the matron of the hospital went, our gynecologist went there because reproductive health is a very big thing there. And we will send the radiographer to go and make sure that they scan, but because of the security issues, especially after I called out one of the staff who was obviously up to no good. In fact, he was so much up to no good that he threatened our first doctor, who was a lovely, gentle soul, frightened him so much that the man left. He said he was happy working there, but he no longer felt safe, so he left. I don't also feel so safe. So security is a big issue. But it's not a big issue in Amai alone. It's a big issue all over Nigeria. and security. A lot of the young doctors who are jackbuying, as we call it now, security is one of the considerations for leaving Nigeria, because one says to oneself, if you stay and you get harmed or your family members get harmed, you won't forgive yourself because you know you had a choice. The second thing, of course, but is also tied to security, is the fact that they are pill-free. So I noticed that I wasn't breaking even. We were supplementing the operations from Lagos. And I kept wondering why, And every time I ask, I'll be told, the patients are not coming, the roads are bad, and so on. We deployed electronic medical records initially, but a reason was given: Wi-Fi is not strong enough, so they stopped using the electronic medical records. So we couldn't monitor remotely as we had hoped to. And then suddenly they quarrel amongst themselves in the last 1 month. And one person says to me, oh, the lab tech has his own lab, and he diverts patients to the lab tech. So the other thing is, of course, that the uptake of the health insurance wasn't as good as I was hoping, because if most of the patients coming in were health insurance patients, then it's the Contributory Health Commission that pays directly to the hospital, not individuals. So apparently, it sort of favors the people who are not as honest as they should be to have private patients and not people on the contributory health insurance scheme. So people were paying into the accounts of the staff of the hospital. So so that's the reason. So when one person reported to the lab scientist, I said to the lab technologist, I said to him, you will either have to close your lab down or resign. So he had to resign. He wasn't going to close his lab down. And he said, well, since they've called me out, I'm going to call them out. And he says, so and so collects money, and this one to collect money. And anyway, the whole thing became a mess. So for 2 nights, I didn't sleep. Each one was calling to report the other. So apparently, the hospital is doing extremely well. However, the money is being diverted. But you see, I blame this. Like I said, this was a very honest community. Their honesty is one of the reasons I was drawn to the community. But I blame it to the lack of supervision due to the fact that the insecurity, the fear of insecurity, and the lack of supervision. So those are the things that I think I would complain about. And of course, the fact that it's also very difficult to get personnel there. So if this had happened in Lagos, I would have taken quick decisions, but I can't take such quick decisions in Amai, because if I let them all go, how will I replace them? So the only option for me is to consider closing down. Because if I sack everybody, because it was everybody, virtually everybody is involved in what's going on there. So the fact that we can't replace them very easily is a bit of a problem as well. Those are the only 3 things I have to complain about. But there's so much that's going on well that makes me very happy. Makes it a very worthwhile venture, makes it a very sustainable venture, makes it a very a good way of reaching the majority of Nigerians who live in communities like that, difficult to reach communities, the people who we like to call the bottom of the pyramid. So in conclusion, what do I think? So I put this gentleman's picture here because I think we all recognize him. He was the biggest champion and advocate of primary health care. Alma Ata was in 1978. In 1978, I was in medical school. He became Minister of Health, I think in 85. I was a young doctor then. He was also a pediatrician like I am now. I wasn't a pediatrician at the time. But when I started my pediatrics, all we ever heard, even when we did, all we ever heard about was what Professor Olikere and some Kuti said about primary health care. I remember go BFFF, growth monitoring, breastfeeding, supplementation, all those kind of things, food supplementation and so on. Focused primary health care, focused, tailored to meet the needs of the people. So in conclusion, I say, with the victory of the Labour Party, better leadership will be assumed. Good policy will be put in place. There is a broken social contract between the governments and the government, and we all know that we don't pay taxes. 6% of Nigerians pay taxes. 6% pay taxes. So because we don't pay taxes, we don't bother what the government is doing with our money. We are the only country where we will hear that we are losing $700 million or $800 million every day, and we do nothing about it. We don't even blink an eye. It's like gist. It's like saying the lizard outside my house died. We are losing $800 million every day to pipeline thefts, and no big deal. I remember being at an event, the August event of August event of St. Nicholas Hospital, where it was the 10th year anniversary of the death of the founder of St. Nicholas Hospital. And the speaker was Sanusi Lamido Sanusi. And he was talking about when he was the governor of Central Bank. And when an announcement was made, or maybe before he became governor, or maybe after he had left. But anyway, an announcement was made about something about the interest rates. And he said, we continued as if, like I said, they announced that the lizard outside the house died. He said, we didn't understand the implication of that change in fiscal policy. But you see, anything goes. Snakes will eat money in Nigeria. And it's a joke for us. Talking about snakes eating money, the lab technician in Amai, after he left, the next day I was told that our auto analyzer was no longer working. And when we sent an engineer to go and look into it, they said rats had eaten the pipes inside. Rats. I'm sure if anybody, we are doctors here, so we know what the auto analyzer is like. Closed. It's like me saying that a rat went into this remote control. It's still sealed like this. No dead rat inside, but rat had entered. So obviously it was sabotage. Okay. So I remember when we were talking on the group about it, somebody said rats eating pipes in the auto analyzer sounds like snakes eating money in Nigeria. But we don't, because there's a broken social contract. But if and when His Excellency Governor Peter Obi becomes the president, we will assume better leadership based on his antecedents. Then we will restore the broken social contract. People will be obliged. People will be encouraged to pay their taxes. And the government will definitely use those taxes for the betterment of the people. Then we will think about sustainable and innovative healthcare financing models. This allocation, budgetary allocation at the beginning of every year is not sustainable and it's not sensible, in my opinion. So we will think of, first of all, health insurance. Health insurance uptake in Nigeria, despite the NHIS that is almost 20 years old, or maybe more, is less than 10%. In a small country like Rwanda, health insurance is over 90%, over 90%. So we will have to think of sustainable and innovative healthcare financing models. So the private-public partnerships, if security is assured, the private-public partnership is a way that can work. And because it is private sector led and private sector driven, and we understand that, I'm happy that Shegun kept emphasizing the fact that I'm not a medical director, I'm a managing director. I have an MBA. So I realized that medicine is a business. And so when you go into partnership with the government, you're still running it as a business. And you're using business principles. You are using revenues minus cost, giving you a bottom line. And so as long as, it's private sector driven, it will be more sustainable in the long term. And then there'll be other innovative ways. Maybe we can get other innovative ways. Diaspora can come in and help. And there will be other ways to go. So there's no doubt that primary health care is still the way to go. It is just as relevant today as it was in 1978 when we had the Alma Ata. And there's no need to reinvent the wheel. Do we need to tweak it? Definitely. It's not the challenges of the world today. Even the challenges of our country today are not what they were in 1978. I remember how immunization rates rose under Professor Ransom Kuti. They dipped again. But this will be the time for us to bring out primary healthcare, dust it, look at it very well, tweak it and adjust it to see how it will work. And it will serve at least 60% of the population. There'll be minimal investment in infrastructure. So no talk, and I will be very happy if His Excellency doesn't build one hospital during his tenure as president, his 8 years as president. What we can do is, we have 30,000 primary healthcare centers, quite decently built too, in various states of disrepair. Those can be renovated. Those can be can be staffed with people who can run them. We have teaching hospitals. We have general hospitals. We have medical centers, federal medical centers. We have enough infrastructure, in my opinion. Let's get what we have up and running first before we now think there might be a need to build. Because what often happens is a lot of money is spent on building this infrastructure, and they're just locked up and the kids taken away. That money for building infrastructure can be deployed to get other existing ones up and running. Healthcare needs should be stratified and which should be utilized appropriately. So there's no need for me to go to Luth emergency room because I have malaria. I should go to a health center for malaria. Primary care primary care should be offered in primary health centers. And then there should be, and primary health centers should be able to offer primary care. They should be able to offer emergency care. Thank God for ALS and BLS. You can at least stabilize the patient and move. In 78, we didn't have ALS and BLS the way we had it then. So everybody did as they like. But now it's very well scripted, and we can, learn the principles of ALS, BLS, and it can be offered at primary level. After all, there is basic life support for bystanders. So if bystanders can learn basic life support, why can't choose another cadre of healthcare workers learn? Urgent care can be provided in primary health care centers. Mental health care can be provided in comprehensive health centers or primary health care centers. I prefer to call them comprehensive because where you're doing cesarean section, appendectomies, and so on, then it's beyond just primary care, in my opinion. So they're comprehensive health centers. So mental health can be addressed there. And of course, we all know that we have a big epidemic. No, not an epidemic, a big pandemic of mental health issues driven by all kinds of things, including social media, the COVID pandemic and so on, the insecurity, insurgency in Nigeria, the economic hardship in Nigeria. This morning, as my daughter was driving to work, she said she saw a lady undressing herself just by a hotel, a nice, well-dressed lady, just started undressing herself and sat on the floor there. That was the beginning. But I'm sure that lady was already showing all kinds of signs of anxiety and depression that were overlooked. Just with screening questionnaires, simple, basic screening questionnaires, PHQ-9, GAD-7, we can pick up and already give some degree of care. And then again, strong referral channels will be established to specialist centers. So the federal medical centers, the general hospitals, the teaching hospitals. Then we should also think about standalone hospitals because because of healthcare, how advanced healthcare is now, people are living.
Shema, have we lost her?
Yes, I'm thinking that she's having some network challenges and she was about to round up her lecture. So so maybe we can give her a little bit more time to come back online. Or while we are doing that, some people may already have questions, so that we can ask the questions, and then when she comes back online, we can transmit the questions to her. But I can see that she. Okay. Please go.
I think I'm back online.
Okay. Go ahead, ma.
I think I'm back online, and I'm almost done. Sorry. Okay. Standalone hospices and long-term rehabilitation. care centers to be established. So not everything in one place. So we will have hospices. So these are new things, that the new ways we must, because these are the various elements of healthcare. There's primary care, emergency care, urgent care, mental health. Then there's specialist care, there's hospice care, and there's also long-term and rehabilitation care. So we should have standalone. I don't think we have that concept at all in Nigeria, but it's time for it now, okay? And then the truth is some of these abandoned structures can be converted into hospices, can be converted into rehabilitation centers without building new hospitals, new structures. Then we should also strengthen social care. We should train social workers. We used to have them before. We should train social workers who can go to homes to find out why the children didn't come for their immunization, why the women have not come for antenatal care. We should have social workers. There has to be governance and accountability. So there has to be some level of training in management, finances, things like that. In view of the Japa syndrome, we have to start shifting tasks. Even in Lagos now, there are things in the past that we will not ask nurses to do, like set lines. But sometimes we don't have a choice but to have the nurses to set lines and let the doctors do other things. So there has to be task shifting. There has to be task sharing. So there's the question of I am a this no longer will be relevant. We will do what has to be done to provide healthcare for our people. We should digitalize primary health. Digitalize, that's the word. Primary health care for wider accessibility. One of the biggest, throughout the pandemic when we were treating COVID and everybody thought Dr. Onya was treating COVID. To be honest, maybe I went 3 times to the COVID center. I was awake almost 24 hours of the day, giving directives by WhatsApp, telling the younger doctors, and not just me, there are about 11 of us specialist doctors in the group, and so all of us on that group are different people. So the endocrinologists having their input, the generalist, everybody is having an input. And so the patients, the young doctors who we put at the front line workers, because we realized very early that COVID did not affect them very badly, were the ones who were doing the work there, but we were supporting them digitally. With the ratio of 1 doctor to 6,000 patients, and now maybe 7,000, and with the continuing jackpot, we better be prepared for, hopefully when His Excellency Governor Peter Obi becomes president, we will start reversing the jackpot. But for now, it is still ongoing. And so what we will do is 1 doctor can manage 5 hospitals digitally. As it is today, we've never employed a radiologist, but we get our x-rays reported by a radiologist. We send it to him by email and he reports. And we pay him. So it's not a favor he's doing us. It's a job he's doing for us, we pay him. And he's able to, and I'm sure he does this for many other hospitals. Our ECGs, we send to cardiologists and they report almost real time by WhatsApp, including the doctor in Amai sends to me and I send to the cardiologist in Lagos and I give him a report real time. Okay. Also, we have to embrace virtual consultation. If one good thing came out of the pandemic, is these virtual things we can do, even these virtual meetings. Imagine before the pandemic, there's nobody will have thought of, if we had even suggested Zoom, everybody would have said, no, let's meet. But I'm sure that people here meeting from all parts of the world virtually. We can consult virtually. So that ratio of 1 to 6,000 can become more effective. And then we can mentor or body a hospital. So the bigger hospitals in bigger cities, the better resourced hospitals can take up, or they can, or 10 primary healthcare centers can be assigned to 1 bigger hospital where you mentor them, you help them become better. Clinical governance, setting standards, guidelines, somebody they can ask when they're in trouble, to give them limits to say, at this point, we think you should transfer these patients. Even you can be watching by video a doctor doing a procedure, and you can say to the doctor, oh God, you can say to the doctor, please, do this and do that. So I think finally, I come to the end of my presentation. I thank you all for your attention. I apologize for my network. So what happens is that when there's power failure, I get thrown out and then I come back. Thank you.
Thank you so much, Ma, for your wonderful presentation. Thank God everything has been on record so that some of us can go back and listen to it again and again and again. And I believe some of these concepts, we need to hold in-depth panel discussions, explore ideas on how we can actually have a policy trust as far as primary healthcare is concerned. Thank you very much. I can see those that are online. I appreciate each and every one of us for coming online. Some of us came a little bit late. I can see Professor Justus Eze came, joined us late, and the rest of us. So if you have questions, please, you can ask your questions. There is someone
Eze is my classmate, was my classmate in medical school.
Oh, wonderful. Maybe I will give Professor Eze opportunity to make some remarks. Please go ahead, sir. I've asked you to unmute.
Thank you very much. I just want to say I came very late. I saw the advert on our platform, and I want to say that I think it has been wonderful. And I hope I will have an opportunity to go through what she has propounded here and make suggestions if there are. But she's wonderful, and I want to say more grease to your elbows. Kudos. Continue firing on, NG. Well done. Thank you for the opportunity to talk.
Thank you so much, Professor Justus Eze. We would like to link up with you after now. So maybe you can just send either myself or Dr. Shegu your contacts, and you can send your feedback after watching it on YouTube or Facebook or Twitter. All right, thank you very much. So there was someone I invited to this platform, but he's no longer here. He's actually thinking of setting up a medical center in one of the riverine areas in Delta State. So he reached out to Doctors for P2B for ideas. So I invited him to listen to some of the ideas and some of the experiences that Dr. Ngozi Onya has, especially in Delta, even though the setting may not be exactly what he's talking about, but I believe he has gotten a lot of insights. Maybe we'll discuss more offline. So I have two hands raised, Dr. Victor and then Dr. Evaristus Afedibu. So I'll give Dr. Victor just 1 minute to ask your question, and then Evaristus, you ask, then Dr. Ngozi will take the questions together. All right.
Yes, good evening. My name is Dr. Vic. I'm logging in from Texas in USA. I just want to make a comment and a little question for Dr. Ngozi. I want to commend you for, let me give you my background. I'm not a medical doctor. I have a master's degree in healthcare management and PhD in healthcare administration. So I do consultation and all that. I have a home health agency. I just want to commend you for what you did in that community. We are doing the same thing in my community in Edo State. I'm from Mission. We are furnishing a healthcare center with equipment and all that shipped from the United States. The question I want to, my suggestion, you actually mentioned it, is for you to liaison with maybe a healthcare center or a hospital in the US or in Nigeria, where you can get some equipment and some advice. So that will help you in your practice. Another thing I want to suggest is that if you want to get in contact with people in diaspora from that community and see what they can do from overseas to help you, that will also contribute to the practices so that it will help you reach a wider population. I really want to commend you for what you did, and I'm going to reach out to you privately and see whatever I can do to help you from this end. I'll do it.
Thank you very much. I appreciate your comments. Thank you.
All right. So, Evaristus, please go ahead.
Okay. Good evening, Dr. Onya.
Good evening.
And thank you for your very excellent presentation. I'm delighted to have listened to you, both your resume, and then I've listened to you. I've also seen what you're able to do, and I'm quite impressed. So I don't have any question really. I just want to commend your efforts, and I want to say that I'm quite delighted because each time you mention that when His Excellency Peter Obi takes over, then this public, policy on health will come to play, and would have formed a basis for his takeoff. And I think I share in that optimism. And I just want to say, well done. Thank you all. And I hope that a better Nigeria is possible with PO. Thank you all.
Thank you very much.
All right.
I don't think we have a choice for a better Nigeria. It's not optional. That will happen. We have children, we have grandchildren who will live in this country.
Yeah, thank you very much. So we have a lot of state coordinators. I may not be able to recognize all of us. This series was actually crafted to benefit all doctors, all nurses, all Nigerians. That's why we are streaming it across the major social media platforms, Telegram, YouTube, Twitter, and Facebook. So people can actually watch, after watching, you can make comments even when we are not yet online. So we have about 4 more minutes to go. I would like to invite Dr. Shegu Ebitami to make some comments about Dr. Peter Obi and what we are planning in the coming weeks ahead. Please, Dr. Shegu, go ahead.
Okay, I will again like to thank Dr. Onya. She has given an excellent presentation. And the way she has gone from a practical point of view. A lot of things we do in Nigeria, we just carry our textbooks, look at what is written there and try. Do not put into consideration as much as possible the environmental variables. So the way she went about it, it's a practical case study. And then, decomposing the case study, dissecting it to let us see the critical issues, I think is excellent. And I'm just so happy that we have it on video and it can be in our archives. These are the kind of videos that His Excellency will watch and he will know exactly how to turn this country around. So I want to reinforce the thank you very much. The Doctors of Peter Obi, right now we are focused on our nationwide medical outreach program and outreach in every ward. We are building a consortium for it. So it's Doctors of Peter Obi in association with Peter Obi Support Network, Take Back Niger, Super Volunteers, Like Minds for Peter Obi, and in Lagos, the police officers' wives for Peter Obi is joining us. Apparently, everybody has a group for Peter Obi. Because when I had police officers' wives for Peter Obi, I said, eh? So the idea is to reach and build goodwill. But as I said, tell a lot of people, this outreach is not exactly what to bring in the votes. There's another strategy of securing the votes, having polling unit managers, funding them, and getting them going out every day and onboarding people to a platform where their votes will be secured. But with the outreach, we build goodwill. In fact, one of our key fundraisers in the US call it happiness, that we build happiness. And with that happiness, we can now sell the mandates of His Excellency. And we'll continue our Health in a New Nigeria series to educate people and to create channels of communication and even mentorship, so that those of us who have battle scars, who have run this system, Who knows where the shoe pinches most of the time? Who knows where we can use 1 naira to get 10 naira? Can share our experience, and the younger ones can take it further. We're enjoying everybody, every doctor to be in the platform. Dr. Onya was in the Lagos platform, and there were just so much messages coming, flying up left and right. She said, Jago, I can't cope with these messages. So I will just stay. And Dr. Onya, I am in about 40 of those groups in Lagos. So that thing you saw in Lagos and ran away, I'm experienced like 40 times of it. And I had to stay because we have to take back our country. So, but I'll keep you posted on key issues, and we'll take it from there. So we enjoy everybody. Take interest. Take interest in what is going on in your environment. We doctors like to complain. Complaint does not solve any problem. I always say when I discuss this that as doctors, apart from the real victims, the patients that are dying, the next biggest victim is the doctors, because most of them will die in the hospital. Within an outreach in Taraba State, saw 5,000 people, 75% of them have high blood pressure. They will come to the hospital. So when the society, when the bad governance in society is dealing with the patient, they are coming to the hospital. And no matter how thick your skin is as a doctor, you can still watch a child die and you won't feel something. So take interest. We are doing each one gets more. If you are in your group and all the doctors we still need more doctors who are obedient on this platform. We are 7,615. Our target is to get to 10,000 as soon as possible. Volunteer for the outreach. Donate. I'm going out preaching, telling everybody that they shouldn't just expect the doctors to finance the outreach. And I really don't think it's fair for just the doctors to finance the outreaches. But we need to contribute our own quota. So we are not saying doctors should single-handedly finance the outreach, but just as we are telling other citizens to donate, we also should donate. No matter how small, donate. Donate your time, donate your energy, donate your expertise. Take up leadership positions in the group. There are still many groups that don't have deputy coordinators or PROs or secretary. Volunteer for all those positions. The more you give, the more fulfillment you have. And finally, remember the power of 10. What we preach in Doctors for Peter is, don't try to reach 50 million people. That is not your business. Take 10 friends and family, 2 of your siblings, 3 of your friends, 5 people in your workplace. Strongly about the message of His Excellency Peter. Convince them why we need to move from consumption to production. Let them know how much waste is happening in this country and the fact that our debt servicing is not even more than our total revenue. Let arm them enough to go and convince 10 people of their own. That's all you need to do. You don't need to do more. Write those list of 10. Convince those 10 people so strongly that they can go and convince another 10. That's the end. If we continue like that, before we get to the 7th person, the whole country is convinced. You will continue to do the outreaches so that when you convince your friends and family, some of them are just coming from the medical outreach, it's easier to convince them. That's the role of the medical outreach. So do your bit, both as a doctor and as a citizen. And I can assure you, a lot is happening, and this new Nigeria is possible. Thank you.
All right, thank you so much, Dr. Shegu, for that. And this closing remark brings us to the end of this episode. 3. So episode 4 is going to hold next week, Tuesday by 7 p.m. And we're going to be discussing secondary healthcare in a new Nigeria. It promises to be very, very exciting. And please, let's find time again to join. So let's just put 7 p.m. every Tuesday in our calendar and come and join us. The Zoom link does not change. It's a recurring meeting. The only link that changes is the YouTube link. Other links remain the same. We are on YouTube, Twitter, Facebook, Telegram. So please, let's go back and share the YouTube links. Thank you very much, everyone, for coming online. Have a splendid day. I'm going to unmute everyone now so that we can say one or two things before we leave. All right.
Thank you, everyone, for listening to me. Thank you for inviting me.
Thank you, Doc. We appreciate you. That was a nice
everyone.
presentation.
Good night.
Thank
Good night.
you, Dr. David. Thank you, Shane. Thank you all.
Thank you very much, the coordinators.
Thank you.
Yes,
thank you,
really,
Dr.
Good night.
Doga, and the
Dr. Ngozi,
coordinator.
thank you very much for this wonderful discourse.
All right.
Thank you for
It's a pleasure.
for you guys' effort in this great mobilization.
Thank you for the effort.
Together we can do better. Good night.
Yes.
Together we can do better, indeed.
Good night.
Hey, Doga.
Good night.
Come
Thank
back
you,
for
sir.
you, bro. All right.
Thank you, sir. All right, sir.
Well, I'll take that.